Hello, I'm Sung-Hoon. I am a professor at the Department of Orthodontics, College of Dentistry, Joseon University, Gwangju, Korea. With my colleagues, I'd like to present a case treated with the mandibular molar distalization. 24-year-old male presented with a chief complaint of anterior crossbite and crowding. He was a dental student and became a dentist, and he participated in this study. He showed 3 millimeters of class 3 on the right side and 3.7 millimeters of class 3 molar relationship on the left side. A and B angle was minus 0.7 degrees and width appraisal was minus 7.6 millimeters, showing skeletal class 3. The inclination of maxillary incisor was normal, but the mandibular incisors were retroclined as a dental-alveolar compensation to the mandibular prognathism. The mandibular plane and the occlusal plane were normal, showing normal divergent pattern. His facial appearance was quite good, and he didn't want surgical correction. The distance between the root of mandibular second molar and the lingual cortical plate was about 3 millimeters. Many implants were placed distal buccal side of the mandibular second molars, and a ligature wire thread was extended from the head of mini implant. 1 week after placement of mini implants, ligature wire thread was tied to the second premolar. On the left side, mini implant was placed without incision. However, it was placed too buccally, impinging the buccinator muscle. 3 months of treatment, mandibular premolars were distalized on the stainless steel arch wire using night-eye close-core springs. Brackets were not bonded on the mandibular anterior teeth to avoid flaring during alignment. 5 months of treatment, spaces developed mesial and distal to the mandibular canines. 7 months of treatment, the distalization forces passed through the occlusal side of the center of resistance of the buccal segments, resulting in distal tipping of buccal segments. Brackets were bonded on the mandibular anterior teeth, and the night-eye wire segment was placed. 11 months of treatment, mandibular left mini implant became mobile and it was removed. Distal tipping of mandibular right and left second molars were observed. 1 year, 2 months of treatment, mandibular molar tubes were repositioned, expressing the distal tipping of molars to unwrite the molars mesially. 1 year, 5 months, finishing bands were made on beta titanium wires. 1 year, 6 months, 1 year, 8 months, right before debonding, post-treatment. Treatment was finished after 20 months of treatment. Superimposition of CBCTs and digital models showed flaring of maxillary incisors, mandibular molar distalization, and clockwise rotation of the mandible. Although the facial change was minimal, chin prominence was improved. These counterclockwise rotation of the occlusal plane and extrusion of mandibular incisors resulted in clockwise rotation of mandible. Along with 4 millimeters of extrusion of mandibular incisors, the alveolar bone became thinner. This counterclockwise rotation of the occlusal plane was caused by the distalization forces passing through the occlusal side of the center of resistance of mandibular dentition, generating a counterclockwise moment. There was 2 millimeters of molar distalization at the root apex of second molars, and second molar roots contacted the lingual cortical plate of the submandibular fossa. Submandibular fossa is the undercut beneath the mylohyoid ridge, and this submandibular fossa can hinder the distalization. Red lines show mylohyoid ridge, and blue lines show the lower border of the submandibular fossa. At post-treatment, the root apices of forced molars were away from the cortical bone of submandibular fossa. However, mylohyoid ridge and submandibular fossa become closer to the second molar roots as they go posteriorly and superiorly. At post-treatment, second molar root contacted the cortical plate of mylohyoid ridge and submandibular fossa. This phenomenon occurs because the mylohyoid ridge turns abruptly behind the terminal molars. This anatomic obstacle may be overcome during molar distalization by the resorption of the cortical plate. However, this may take time and can move the center of resistance and center of rotation more posteriorly, increasing the extrusion of incisors. During 9 years of retention, occlusion was well maintained. Yellow shows the post-treatment and blue shows the 9 years of retention. During 9 years, there was bone apposition on the mandibular border. There was no rotation of mandible during retention. Clockwise rotation of the mandible during treatment was maintained. Mandibular incisors were intruded spontaneously and the maxillary incisors erupted accordingly, improving the exposure of the maxillary incisors. Although the mandibular incisors were intruded spontaneously during retention, the alveolar bone was not thickened. Initially, there was mild washboard-shaped alveolar bone scalloping at the incisor region, and this was exacerbated during treatment due to extrusion of incisors. This was not improved during 9 years of retention. To conclude, when there is an anatomic obstacle, mandibular molar distalization causes extrusion of mandibular incisors. This extrusion can thin the alveolar bone, and this may not be recovered during retention. Thank you very much for watching this presentation.